got a very important role in the diagnosis. It plays a very important role in both internal medicine and surgery. Okay, we have a lot of diseases here to learn, and also uh, since since it plays a very important role in the diagnostics. So what we have to uh, be is that we have to be very familiar about all the diseases that have been mentioned in these chapters. Okay, uh, not only because of its diagnostic use, because of its complexity, and because of its importance in the diagnosis. So this chapter is technically considered to be very important, all for examination purposes and also diagnostic purpose in a hospital. So please do not ignore these chapters. Okay, recognizing gastrointestinal abnormalities and recognizing the intestinal obstructions. Both those chapters are very important. Okay, so try to pay a good attention to the situations here. I will try to make them easy so that actually you can understand the complex phenomena involved with these ones. Okay, so today we're going to start with recognizing gastrointestinal abnormalities. Okay, in this chapter, we will try to learn some of the most common abnormalities that frequent to a clinic or frequent to a hospital in the gastrointestinal tract, starting from the esophagus and then to rectum. Okay, we will be learning uh, about the different modalities like computer tomography, ultrasound, and magnetic resonance imaging, which has eventually replaced conventional radiography. But still, we know this as a fact that computer tomography, MRI, and ultrasound are sometimes proven to be very superior to most of the diseases. But unimaginably, there are few conditions uh, in medicine that actually you have to use the principle, the basic technology which has been invented 100 to 200 years ago, right? See, the situation is like this. For example, to say, I am trying to look at the esophagus problems, I'm trying to look at the stomach problems, or I'm trying to look at the duodenal problems. Not every time a CT or an MRI would be able to tell me the complete evaluation of that particular organ I'm looking at, especially any kind of a disease that is related down to these tubular structures. Most of the times, yes, we will not be able to get the complete information what we wanted. So that's the reason we still be using one modalities. Break lo break lo So in the recent times, what we actually try to do is that first we try to analyze the patient with a basic investigation for something like conventional X-ray, and then we try to forward the patient down to computer tomography or an MRI, depending upon the condition of the patient. And then if we are still trying to get down some kind of a therapeutic and diagnostic value, and we still wanted to analyze the case in deep, uh, so at that point of time, we are trying to prescribe some kind of an advanced study. Well, we cannot say it is completely advanced, but we can say it is fairly superior than some other modalities what we have here. So what we try to do is that we try to get down in the overall evaluation of the GI tract. See, the overall evaluation of the GI tract is always done by fluoroscopic studies. Okay, uh, so uh, fluoroscopy is this in this chapter. Actually, I have left a fluoroscopic topic in the general principle just because I wanted to cover it here. So we will be learning in detail here about the protocols, about the technique, and about the views and different ideologies here. But however, I have given you an introduction, I guess, right? So right now we will be dealing mostly about the barium studies. Okay, we will be leading about fluoroscopic techniques and ideas. So pay attention to this class because this is a little confusing. Again, it is not complicated, it is just confusing. Okay, it is fairly easy, but a little confusing. There is a lot of anatomy, lot of pathophysiology and pathophysiology that you need to correlate here. So that's the reason I will try to be very slow, and whenever you have a problem, whenever you have a doubt, you just let me know and we will try to learn that one. Okay, so the first things what we do is that we will learn about some terminology. Then we will go along with following the same anatomical distributions. So we will start with the esophagus, then go down into the stomach and duodenum. Then we will go to small bowel and large bowel. Okay, so we will try to complete as much as we can in today's class. While we are trying to do, we will also learn about the protocols of each of these procedures, and then we will also try to learn the alternate procedures also that might help down in the diagnosis. Okay, so let's start with it. We'll try to learn from some terminology first. See, like you remember in the previous classes when we are learning about the general principle, you can understand that fluoroscopy is a technique that actually utilizes X-rays. Okay, but the difference between a conventional X-ray and a fluoroscopy is that the equipment actually produces images in real time, analyzing the dynamic movement of the bowel and optimally positioning the patient so as to obtain a diagnostic images. So in a fluoroscopic patient, generally it utilizes X-rays. Okay, but the only difference is that we are trying to move the patient, okay, in different positions. Technically not moving it, we are actually moving the examination table in different positions, and we will try to use some kind of contrast materials. Okay, the most important contrast material that we use here is barium sulfate. Okay, and then we try to achieve the dynamic momentum of the images, and as the contrast material passes down through these intestinal tracts. Okay, starting from the mouth and till rectum, we have different procedures. But for the whole hollow organs, from starting from mouth to anus, we will be using barium sulfate itself. Okay, but the procedure may be different. For example, to say when we are trying to analyze the upper GI tracts, we are going to give him barium swallow and barium follow through. Then we are going to get down into the lower intestinal tracts. We are going to use a special technique called as barium enema. I think you have already learned about this one before, right? So we are talking about those techniques today, and we will try to familiarize ourselves a little deeper into the things. So here, fluoroscopy utilizes X-ray, producing real-time dynamic movement of the bowel and optimally positioning the patient so as to obtain diagnostic images. So, and these kind of diagnostic images obtained are referred to as spot films. Okay, spot films is that, yes, they look same like X-ray, but they will be taken down as a series. So same like in a what do you say, in a CT scan, that you have a single patient will have multiple slices, something around like 300 to 400 slices. But here in fluoroscopy fairly we will be having something around like 10 to 15 images which will be taken within limited time intervals in between, right? So 15 to 20 images we obtain actually are taken over fixed time. For example, this day I start now, first image I take now, and then I will take some image after some time, something like 10 minutes, 15 minutes, or 20 minutes, or something like that. Depending upon the indication of the disease, I will actually try to take more pictures. So obviously, you have to understand that fluoroscopy has got a, particularly it takes a very long time, okay? And then it also has got a radiation risk. And yes, it is uncomfortable to the patient, but still, its benefits outweighs its risks. It provides a very, very high diagnostic information. And most of the times, yes, a physician must be aware of these techniques. So, like I said, yes, barium sulfate is the contrast material that is used. Barium sulfate is an inert substance, radio-opaque material prepared in liquid form, and it actually passes down and it is ingested down to different routes, mostly by oral, and sometimes we also do it by rectal administration. And why do we use that? We use that to study the intraluminal anatomy of the GI tract. So, utilizing the theory that is present down in anatomy, we are trying to analyze the condition, the real-time condition of the pathology, right? So, based on a technique of physiology, for example, let us say there is a problem inside the esophagus. Problem inside the esophagus, let us say it has been, completely narrow. I will not going to talk about the disease yet, but it has been narrowed because of some kind of a problem. What happens is that right now I am trying to utilize fluoroscopy to observe this anatomical restricted movement or anatomically restricted organ, to observe which kind of a pathology is causing it by utilizing and waiting until this physiological process is completed. So it means to say I am getting complete information about its anatomical state, about its pathological condition, along with its physiological efficiency. Okay, so I am getting a very detailed information. So that's the reason most of the times when we are trying to observe uh, or utilize fluoroscopic images, what we get is that it provides an invaluable, diagnostic information related to the GI tracts. So it plays a very, very superior role, right? So in this fluoroscopic things, we are just trying to utilize, different kinds of techniques, uh, which actually called as a single contrast, okay? Or sometimes we use a double contrast, or we also use a biphasic examination, okay? So let us try to see a little differences between them. They are not too difficult to understand. A single contrast, also called as a full column, okay, study usually refers to a GI imaging procedure in which only barium is used as the contrast agent. So remember, a single contrast, the name itself indicates that we are trying to produce an image of the GI tract utilizing only barium sulfate as the contrast agent. Okay, so that way. Then in double contrast, we are going to use air as the contrast material, okay, and use thicker barium and air together, okay. So the technique in double contrast is that we are going to use the barium, which is technically much more thicker, and also air. So we are going to ingest air, and we are also going to ingest barium together, so that we can actually find out the difference. So that's actually called as the double contrast study. Remember, Double contrast study is actually used in such kind of a way in an anticipation, something like based on the physiological process of the intestines. See, like when we are learning about the basic anatomy of the GI tract, we came to understand that there is air present at different levels of the GI tract. So, which means to say air is a natural component of the intestine, not only intestine but also stomach, okay, because it has got a connection, a direct connection with the external environment, right? Because the mouth is quite open to the external environment, the same way rectum is also open down to the external environment. And simultaneous movements of these muscles are all over along the oral cavity or along the rectal area. You know, yes, there is a possibility of air entering down into these, uh, hollow organs. So, which means to say, air is a natural component of these organs, right? So, we try to introduce, let us say, if there is a condition when there is no air that can actually, enter down into the this cavity, it means to say there is a problem. So what we try to do, we try to get down air into that area and try to see how exactly air that is being distributed. So for example, to say, let us imagine a condition of intestinal obstruction, or let us imagine a condition of GI, stomach cancer. So we try to utilize a single contrast examination, or we are trying to use a double contrast examination and see how the barium flows through, or how the barium reacts to the surrounding structures. So that is actually providing us the real-time evidence of the condition of the patient, right? But the third examination, a biphasic examination, is generally used to study the upper GI tracts and utilizes initial double contrast followed by a single contrast agent to optimize the study. See, the only difference is that, okay, yes, biphasic examination is something that we initially use a double contrast study, which means to say we are using both air and barium in the first, and then we are just giving out the single contrast agent. It means to say we are virtually creating an environment so that this one actually, poses down as the food particle that is trying to enter down into the GI tract. So that is the benefit of the biphasic examination, right? So you have to, in this class, we have to just know about the differences, but we are not technically going to get into more particular details of this one, all right? So remember, a single contrast usually refers down to only barium sulfate being used as the contrast agent. Double contrast is refers to using thicker barium solution and also air. A biphasic examination is utilized generally for the study of upper GI tracts, and by utilizing, initially double contrast study followed by a single contrast agent. Okay, this is actually done to optimize the study. All right. So is this clear? Is there any confusion here? Yes, no? Is there any confusion? Okay, right. Okay. Now, when we are trying to understand here one thing, like I actually also, I think I remembered you that I have already introduced this terminology to you so long before, right? But let us try to revise once again. The first thing we are, Shubham is trying to ask, okay, both the thicker and air means, no, both thicker and barium. You see, generally in a single contrast study, barium is not made with high consistency. Okay, how can I actually say? Okay, it is just a difference between a curd and a buttermilk. Okay, Simple. Did you understand? Right now, yogurt becomes a thicker barium, whereas the buttermilk becomes, lighter barium. Consistency is different. Okay, thicker barium, high amount of barium with more consistency, and less amount of barium with diluted barium with less consistency. Okay, you get it? Uh, yeah, viscous, generally viscosity means to say, yeah, we can almost say it is viscosity too. Okay, right. Thicker barium, yes, it is about the consistency, concentration of the study. I think if you wanted to know about these concentrations, I think you need to get down to the general principle slides. I think we have a pretty detailed explanation down there. How do we barium preparations? Actually, you need not study about this barium preparation or something, because you will not be actually, as an MBBS doctor, we will not be uh, you know uh, supposed to uh, prescribe these studies. It is actually a professional thing, but still you will be able to look at these x-rays. So that's the reason we will be concentrating more on diagnostic purposes, but rather than prescription of these purposes. Okay, right. But if you wanted to learn about that one, yes, the information is already there in the general principle slides. Actually, I don't want to get into more details of that one, because uh, there are so many protocols that are related to this one, which actually you need not necessarily learn at this level. All right, but still, okay. Let's try to learn about some of the important terms. Okay. If interested, yes, I can provide that information, but let us complete the chapter first, and then, yes, we will get down to the extra information there. Okay, first things, what you actually need to understand here is, let me try to uh, let you make you here. Okay, can everybody see the whiteboard? Yes, confirm. Everybody see the whiteboard? Okay, right. Okay, see, let us say I have got an X-ray with me. So what I'm trying to listen carefully when I'm trying to actually tell about this. See here, let us imagine I have got stomach here. Okay, right? That is the greater curvature, and this is the lesser curvature, right? So let us imagine that I have given a barium contrast material. Okay, barium contrast material is white. So what happens? It slowly and slowly forms, coming down like this. Okay, it is forming over the mucosal membranes like this, right? It is forming as a thick substance with high consistency, and it is forming somewhere and slowly filling up the stomach like this, right? So it flows and flows on, right? This is the basic thing. But let us imagine a situation. Okay, usually the whole barium has to completely line all over the mucous membranes, right? Okay, if this is a normal patient, okay, if this is a normal person, what actually happens is that everything should be filled up and no mucosal changes should not be happening in this patient. But let us imagine a situation where the barium is actually being filled all over the place, but just not a single place. See, let us say it like this. Um, I may not be actually correct, but I'm just trying to let you understand. Okay, it actually doesn't look like this. Okay, uh, so don't try to make an analysis or a diagnosis out of this one. I'm just telling you the theory behind it. Now, you see here, look at this image very carefully. It is white. Here, it is white. It is white. But here, I can see a small area that is black. Yes, if I call this one as the filling of the barium all over, okay, it is about the filling of the barium all over the surface, but there is one defective area where the barium is not being filled. It is called as a filling defect. Simple. Is there any confusion? Did you understand this one? Yes or no? See, the thing is that, okay, there is an area in the GI tract, somewhere, anywhere. Let us not only say in the stomach, but the classical example we use is always stomach. There is an area inside the uh, mucosa, which actually the pathology of that area actually causes the filling of the barium not to happen. So what exactly it means to say, it is causing a particular defect in the filling of the barium, and that is called as a filling defect. Simple. But let us see what actually condition, which kind of conditions actually cause this one, and why is it actually becoming down a defect. Now let me try to get down something like this. Okay, let me say I got a mucosa like this. Okay, this one, okay, I'm actually, maybe let me make it better like this, because it is the effect of the gravitation, right? Like this. Okay, like this. Now let us try. There is a mass that is present up here. There is a mass that is present up here. Okay, now let me try to pour some thicker barium so it falls here. Yes, then what actually happens is that this is a mass, this is a solid structure. So what actually tries to do is that, okay, this one, it means to say it has got its own mucosa. Now the barium starts slowly filling up here like this. And since this is not hollow, this space is not hollow, so that's the reason there will be no filling up of the barium. So barium will fill up all this way, here, 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 right? Okay, and then also the same thing here. Okay, that's happening here, right? So filling, filling, filling. So all other areas are filled up with barium, but only these two areas are not filled up with barium. So that is why we call it as a filling defect. So filling defect technically has to suggest you that you might be looking at a tumor. Okay, so simple hint, filling defect anywhere in the body actually has to suggest you that there is a tumor. Well, Benedict has been asking down a very interesting question. Won't the luminal filling be affected by the peristalsis? Of course, yes. Of course, yes. But it does. It may change the position. The peristaltic movement actually changes the position of the, filling defect location, but not the effect itself. See, doesn't matter. Even this whole, gastrointestinal tract. Okay, let us say here, this is, I'm talking about the stomach in particular here. So even if this is happening, let us say this one has caused a peristaltic movement around this place and here, this place, right? Maybe because of the peristaltic movement, maybe the tumor will be moving something like this and changes its location rather than being on this plane, right? It should have been on this plane, but right now it is not being on this plane because of the peristaltic movement. It is just changing its position. But still, filling defect, even the barium actually coming down from here area. So the size may vary, Okay, the location may vary depending on the peristaltic movement, but the defect stays. So which means to say, even by this I came to understand that yes, this is a tumor, but it is not something else. Did you understand? Yes, Benedict? Yes, no, right? See, but let me try to give you another example, okay? Let us try to imagine, so, okay, there is a, let us say this is the esophagus, okay, that I will try to use more classical examples. I will, okay, please do not make a conclusion from this uh, theory, okay? It is just you need to try to understand a term which is called as a filling defect. But diagnostically, yes, there are another rules and regulations, and there are simple radiographic features that should be seen. But I'm just trying to give you down the basic theory behind it. Let's try to imagine that this is esophagus, okay? And let us say there is this diverticula that is formed around the esophagus. Yes or no? Right? So what actually happens is that when I'm trying to give down the barium, what actually it does like this. Hey, can everybody hear me? But what happened? I don't know. Maybe I got lost here. But can't see the screen. Uh, just, I don't know why. Okay, sharing has been. Okay, right now. Why somebody has shared my screen and I have lost the connection. Okay, please don't do it, all right? Yeah, somebody skipped it off. Okay, so you see here, there is this diverticula, okay, which started slowly filling up of the barium. Now, you see here, actually, this should have been a mass, okay, that is present outside here. So there is an extra filling of the barium here, right? But the barium is not actually flowing from outside. Actually, barium is flowing inside. So you call this one as, now let us say the peristaltic movement happened, okay? Peristaltic movement happened like this, and the diverticula became completely a little bit narrower like this. So the barium went on, filled up here, okay, and then moved on. You see here, even the peristaltic movement happened, but still the property of the barium going in or coming out did not change. So yes, the location may change. I mean to say the position of the the position of the pathology may change. The view of the pathology may change, but the property of the pathology won't change. So luminal peristaltic movement generally won't cause any, won't cause any kind of a problem with the diagnosis. Okay, I think this should be much more better right now. Yes or no? Can everybody understand? Yes? Right. Okay, so let's continue with the other things. Okay, so fill is a lesion usually of a soft tissue density that protrudes into the lumen and displaces the intraluminal contrast. Okay, so you see here, remember, it's a lesion which actually a soft tissue density, obviously, it's a mucosal density, and then that protrudes outside the lumen, okay, protrudes into the lumen, and that causes the displacement of the intraluminal contrast that is falling over it. So generally a mass, a polyp, it actually causes a filling defect. So what is the reason behind it? The reason behind it is that, okay, since it is a solid structure, so that's the reason there won't be filling up of any kind of material over to it, because the barium flows over it and causes no settling of the barium, which is nothing but a defect caused in the filling of the barium. Simple. Okay. But let us try to understand another theory here, actually called as an ulcer. Okay. Now imagine what happens in most of the ulcer things is that, okay, let us say ulcer is the erosion of the normal mucosa. Let us say there is a normal mucosa like this. Barium continuously flows on, right? Barium comes about, okay, doesn't matter how I give the barium, okay, it flows and flows on, so its direction is going down into the gastrointestinal tract, okay, lower gastrointestinal tract later on. But let us imagine there is a erosion of the mucosa, which actually caused a ulcer. Yes, erosion of the single or multiple layers of the intestine or the gastrointestinal tract is actually called as an ulcer, right? So, which actually forms a crater, a extra space. So now what happens? Now, when the barium is trying to come, what actually happens is that it comes and comes and comes and slowly fills up this area. Okay, it filled up this area more, and then also it filled up other areas like this. Can you see there is some kind of a problem like this, a extra indentation with the complete filling, extra filling? Now let us try to imagine and look at this. Okay, this is when I'm trying to look at a particular cross-sectional view like this. But now let us try to imagine to look at the same patient in a different view like this. Now, let us say this is a mucosa that I have been looking from the side, okay, on the lesser antrum of the stomach. Okay, let us say I'm looking at like this, lesser antrum of the stomach. Okay, an extra filling of the barium like this. Now, this is the greater curvature. Okay, now let me turn the patient. Let me turn the patient, and so that I can only visualize only the lesser antrum. Now I am visualizing the lesser antrum like this. The whole is lesser antrum. Okay, I'm just trying to look it from the side. Okay, so that the complete folds of the lesser antrum came to be visualized. Now, what actually happens? You see here, the barium flow is happening. At the same point of time, peristalsis is happening, right? Let us say that now the ulcer looks like this. Okay. Now, over time, when all the barium has been passed, all the barium along this mucosa that has been filled up before has been passed. But since this is a depression, well, now what happened is that, okay, there are a lot of barium that has been collected right now here. So this is what I'm looking at. Okay. Did you understand? Yes. Right. So that is what the how the diagnosis is made into a a ulceration and a ulceration and a generally a tumorous condition. So it is about that. Yes, in this condition, yes, Benedict, yes, luminal peristalsis actually causes a particular area to fill up with barium. Because the all other barium, depending on the natural physiology, what happens is that all other barium has been dried off, washed off. Okay, so washing up of the contrast material, okay, washing up of the contrast material, see, refers to a persistent collection of the contrast that projects outward from the contrast-filled lumen and originates either through a break in the mucosal lining or in a GI mass. So most of the times you cannot, you will be actually looking at this one, but please do not confuse with this term here. Okay, it might be happening in the breakage in the mucosal lining. Okay, ulceration is nothing but the breakage in the mucosal lining, as simple as that. But what do we actually mean by breakage in a mass? You please do not confuse how does a mass break. Well, in GI tract, the risk of developing gastric cancer, okay, gastric adenocarcinoma, the most important risk factor is the ulceration itself. Okay, first ulcer comes, then heals. Healing causes fibrosis. Fibrosis looks like a mass over time. Again, ulceration happens over that. Again, heals. Again, fibrosis. Again, mass. So becomes bigger and bigger and bigger and bigger over time. So yes, gastric ulcer is one of the most important predisposing factor to cause a gastric carcinoma. We will talk about that when we are dealing about the diseases, but please do not confuse how here even mass is causing an ulceration like density collection. No, it's not like that. Filling defect generally indicates that there is a mass or a polyp. Ulceration is a contrast, persistent filling of the contrast because of the breakage or the erosion in the mucosal lining. Generally happens in a gastric ulcer condition. Okay, clear? Right. Then a diverticulum is the collection of the contrast that projects outward from the lumen. Okay, like I said, it is the outward from the lumen, what we have just seen before. Okay, so diverticulum is an outward projection of the contrast filling. And diverticulum, unlike the ulcer, the mucosa of the diverticulum is much more intact. And a false diverticula represents the outpouchings of the mucosa and the submucosa through muscularis layers. Okay, we will talk about this one slowly, but just try to understand that we have three conditions: filling defect, ulcers, and the diverticulum. Remember these definitions, they are very important. They can be asked as an MCQ or a fill in the blank or an image or just about the different basic patterns of the fluoroscopy. Okay, then we have few things: spot films and overhead films. Spot films are nothing but the spot films usually refers to static images obtained by the radiologist who utilizes the fluoroscopy to position the patient for an optimum image. Overhead films is a term that refers to additional images obtained by the radiologic technician to complement the fluoroscopic spot films, so utilizing X-ray tube mounted on the ceiling of the radiographic room. So see, something like we are utilizing two different cameras to focus a single person. Okay, it's as simple as that one. First, the radiologist uses a a position and get one better image. Then overhead film is the thing that actually refers to the additional images obtained by the radiologic technician to complement, okay, to add with the get different images at different seconds. Okay, so with the second differentiation, not minutes to hours differentiation, but to seconds differentiation, so that you can actually get a series of that film. Okay, one image is technically more than enough. See, even when I'm trying to show you the filling defect, when I'm trying to show you the diverticulum, or when I'm trying to show you the ulceration, we just used one film, right? So it doesn't matter the property of the barium flowing over different lesions doesn't change. That's what we observed, right? So getting me one accurate image is more than enough. But you have to understand fluoroscopy has to be quick. Fluoroscopy only during the time that the barium is not filling on the mass, only at the time that the barium is trying to fill over the ulcer, that is the only time I have to take down the film. So how can I do it without looking? So that's the reason I will keep the patient under constant exposure of X-ray. And immediately when I start seeing a lesion that is being doubtful, I take an image there. And the radiology technician actually continues to take down the image whenever that it has been prescribed. So which means to say, if I have missed taking down the film when the barium is filling or not filling, obviously it means to say I have to reschedule my investigation again. So it is a very, very precise investigation. Did you understand the biggest drawback here? Yes. Let us say, for example, to understand in simple terms, okay, you are hungry right now and you wanted to eat food. But if I do not give you food at the time you are hungry, don't you feel bad? Don't you think that you will have a good image of me in your brain? Of course not. That's the same thing is happening here. Okay, when the barium is trying to fill over the ulcer, well, the barium is trying to flow over the mass, I have to take an image immediately at that point of time. But if I did not take it, obviously I'm not going to get a good image and my whole diagnosis is going wrong. Did you understand the difficulty and why I need to put the patient under constant exposure of the, radiation? So that's one of the biggest drawback of fluoroscopy, but still the diagnostic benefit, the diagnostic, value that this one is providing actually in real time outweighs all its risk factors. So it is a very superior study when compared to the CT or MRI in relation down to the gastrointestinal tracts, especially with the diseases of the mucosa. So I will get spot films and overhead films, right? Then I have intraluminal, intramural, and extrinsic, okay, lesions. Remember, we will try to get about this one in more detail as I'm trying to move down into the pathologies. But first understand here, intraluminal, it is present inside the lumen, and it means to say it is arising from the mucosa. So best examples are polyps and carcinomas. Intramural, it means to say it is coming out from the wall, which means to say it is coming down from the muscularis layer of the intestines. So it means to say it is intramural lesion. Okay, which example is leiomyoma and the lipoma. Then the extrinsic lesions that actually arise outside from the GI tract. Example to say serosal metastasis and endometriosis implants. So there are three types of lesions that we will be observing. Intraluminal, best example is a polyp or a carcinoma. Intramural, it means to say it is coming down from the muscularis layer of the intestines, and it is showing up as best examples are the leiomyomas and lipomas that actually arise from the wall. And then we have extrinsic lesions which are outside the GI tract and serosal metastasis and endometriosis implants. So three types of different lesions, okay? And each of them lesions can show ulceration, filling defect, or can be taken down in the spot films and can also be taken down in the overhead films. So it is a complex, mechanism here. Then we have different views. One view is that an invasive view or a profile view. Okay, we have two views here: invasive view or an in profile view. What is an invasive view? Is that when you look at the lesion directly head on, when you are seeing it in face, you are looking it directly face to face. Okay, that is a invasive view. But when the lesion is tangentially, when you are trying to look at it tangentially from the side, which is a profile view. So do you remember the image that what we have just seen with the ulcer? I have changed my view from side to face so that I can actually see the complete circulation of the ulcer. But when I'm trying to look it from the side, actually I used it an in profile view. So invasive view and in profile view are those one, except for those that are perfect spheres. these lesions will have different shape in viewed in invasive view and a profile view. Did you understand? Even in the image that we showed before, actually one is just looking like only an curve. But when I changed the position, when I changed my view, it became completely circular, right? That's the same thing actually happens. That's the same thing actually caused by the peristalsis as well. So the position, the spot film or the overhead film or the invasive view or in profile view actually changes how the lesion will look like. But still understand the basic lesions like a filling defect and ulceration, they do not change the property. Doesn't matter in which view you are looking at. Yes, they may change the shape, they may change the position, but they do not change the property of the lesion, how it is behaving. So mucosal ulceration actually causes a crater that causes extra filling up of the defect, a filling up of the barium. A mass does not technically cause the barium to fill it into its lumina. So that's the reason it passes over. So it causes filling defect. So filling defect stays anywhere the same. Ulcer crater actually fills anywhere the same. Did you understand right now? So the property of the basic lesion do not change, but the shape may change, the position may change. You understand it right now? Is this clear? Yes, no, guys? Right? Okay. Then we have full distension and collapse. Okay, full distension means to say only the loops that are fully distended by the contrast can be accurately evaluated, which means to say wherever the part that one is collapsed, we actually cannot look at that one. But don't you think so? This one also provides some kind of a basic information. Let us say there is one part of the intestine that is fully distended and the next part of the intestine that is not completely distended. Okay, I can understand that. Yes, there is some kind there is an extra distension of this one, dilatation of this one and the proximal levels, but in the distal levels it is not showing up any distension. By this I can understand that it can be happening because of some kind of a condition called as stenosis. Yes or no? So even the information coming down from the distension versus collapse also technically tries to give you some kind of a valuable information. But only collapse happened, but only distension happened, sometimes yes, there might be errors in the diagnosis, but we are technically very least concerned about this one because this is highly highly professional point of view. It may take a little difficult for you guys to understand at this level, but still understand one thing, that the fully distended versus collapsed images or the intestinal contents actually shows, yes, sometimes they may actually cause the errors of the diagnosis, sometimes, but not actually. So that's the reason we are trying to make some certain criteria such as the wall thickness into consideration while we are trying to make this kind of a diagnosis. So every collapsed intestine is not completely a pathology. Okay, it can be happening. Maybe I have taken down the picture at the peristaltic movement when it is going on. For example, to say when I take the image in the cardiac systole or cardiac diastole, it doesn't technically mean to say either the heart has been atrophied or the heart has been completely dilated, right? So it was my error to take the X-ray in not in during its physiological process. Yes or no? Right? Did you understand? It's the same theory what we applied there in respiration. It's almost the same kind of theory that we are applying here. So we technically have to take here the wall thickness into consideration if I'm completely trying to analyze if it is a fully distended bowel loop or if it is a collapsed loop, because there is a possibility of diagnostic error, right? And then change and distensibility over time, what actually happens, usually in seconds. Okay, the walls of the GI luminal structures from esophagus to rectum change in their contour. Obviously, every mucosal layer is under in constant movement, so either it is causing distension or the ballooning of the outward with the increasing volumes of the barium or air. So more food enters, more peristaltic movement is happening, more mucosal distension can happen. Yes or no? So because it is actually happening because of the effect of gravity, and all the contents has some kind of a mass to it. So which means to say it is causing some pressure or thrust over the mucosa. So generally, yes, it will usually cause a change in the distension properties. So the more the food, or the more the barium, or more the amount of air, more increase in volume, and more ballooning and more distension of the mucosa. So generally, this change and distensibility are normal. But you have to understand, you have to remember the properties, okay, which area, which movement is normal, which movement is not normal, which distension is normal, which distension is abnormal. So unless we don't know them, it means to say we are going to learn about the peristaltic movements as well as today. Okay, we are going to learn about the process of digestion, influence of peristaltic movements on all these structures, and try to understand slowly and slowly, one by one. Okay, then we still have, other than distensibility, we will be having stiffness. Some areas actually try to move, some areas of the intestine technically try to move. So they might be rigid, stiff, and fixed and non-distensible. For example, to say, whenever there is a fibrous tissue, it actually does not move, right? The same thing that is like happening in the atelectasis, this one is also not trying to let the intestine move in that particular area. It might be happening because of a tumor. It might be happening because of a blood collection, blood clot, or it can be happening because of the edema, which has actually, the receptors have been completely blocked. So all these things, everything is actually causing some kind of a non-movement, because remember, the whole GI tract is made up of smooth muscles. So there will be rigidity, there will be tonicity, extra tonicity, there will be rigidity, there will be flexibility, there will be different positions that are being acquired. So what actually happens is that it may either lose the ability to change or distend, and this lack of distensibility is variously caused as rigidity or stiffening or non-distensible. This is certainly abnormal, which means to say a GI tract that is under constant movement is a healthy one. But a rigid abdomen or a rigid gastrointestinal tract generally indicates that there is a serious abnormality. So we are trying to utilize this theory of all the process of digestion over trying to find which one is particularly normal and which one is particularly abnormal. Irregularities, yes, all the mucosa doesn't necessarily seem to be, uh, you know, uh, all the mucosa is technically almost the same lining, okay, at different parts. Okay, esophagus has got some lining, gastrointestinal has got some lining, or to be accurate, I can say that, okay, esophagus has got you know squam squamous epithelium or columnar epithelium, depending upon the condition. Okay, or the gastrointestinal mucosa has got columnar epithelium, or intestinal mucosa has got columnar epithelium. So all these epitheliums, wherever they are being covered, they have some kind of a regular property. But if this one has been lost because of dysplasia, because of metaplasia, because of hyperplasia, or some other conditions, what actually happens? There will form irregularities. So recognizing the irregularities in the mucosa, or the indentation, or the mucosal layerings, also gives you some kind of information, right? So they can produce ulcerations, they can produce infiltration, they can produce a nodularity, and which actually results down into the irregularity of the wall. So looking at the irregularities of the wall along the mucosa gives me different kinds of information, right? And then persistence, almost without exception, what actually happens is that apparent abnormality must be seen in more than one image, which means to say I need to, have a persistence. I need to stay down there. I need to get more images, okay, depending upon the condition. Okay, so one image is considered to be a pathological finding, and I need to get more images to confirm the pathological finding. So also the changes caused by the peristalsis, type of food ingested, the presence of a stool, or the incompletely distended bowel loops will actually disappear over time. But it means to say other changes that are normally whatever we have seen before, they are normal, they can change over time. But true abnormalities will remain constant and persistent. That's the final secret here. You see here, the pathology do not change whatever happens to it. Okay, rigidity, flexibility, distensibility, okay, overhead view, it does not change, doesn't matter. All the properties remain the same for a pathological condition. So which is a best thing here? That's the reason I am going to get an accurate diagnosis of whatever the condition I'm looking at. Okay, if I'm looking at an ulcer, yes, accurate information of the ulcer will be provided to it, because I am trying to understand which one is normal and which one is abnormal, because a true abnormality will remain constant and persistent, doesn't matter how I am looking at it. So that is what persistence is. Yes, even though I have stayed down for a long time, even though I have got one or more images over time, I have been persistently, patiently taking down a lot of images, but still, so over this time, what actually happens? GI tract changes might happen because of peristalsis, ingested food, and the presence of stool and in distension or something like that, but they do not cause any kind of change in the pathology. Yes, is this clear right now? Benedict, I think this here is your answer, a complete exact answer that is here, right? Is this understandable right now? Yes, no? Guys, right? Okay, so remember simple thing that the pathology generally do not change its property because it is constant and persistent. Okay, so let's try to take a break here. Okay, I think we have completed the basic terminology. We'll try to get down into the uh, anatomical structures, and then we'll try to evaluate one pathology by one. Okay, so it is 11:50. Can everybody see the screen? Yes? Okay. Right. Okay. So we will try to start with the esophagus first. You need to understand one thing here, that single or double contrast, or sometimes both, or examinations are the one that is prescribed for analyzing the esophagus pathologies. Okay, so what actually happens is that when the patient drinks liquid barium, okay, either by itself, which is actually called as a single contrast, so only barium sulfate has been used, that has been ingested through mouth, so it forms a single contrast, or accompanied by a gas producing agent that provides air inside the tract, actually called as a double contrast examination. Okay, so single, both, and double contrast techniques have their own strengths. Many esophagograms, okay, the image that is obtained here is actually called as an esophagogram, are routinely performed using these both techniques, and so that's the reason it actually becomes a biphasic examination. All right. So esophagus is generally analyzed with a single or double barium contrast. Okay, and then when we try to use both of them together, initially when we use the double contrast and then we use the single contrast together, actually is called as a biphasic examination. Then what we actually do here is that video esophagography is taken, so which is monitored under video fluoroscopic examination, which is called as video esophagography. And we will try to get images during the process of deglutition. So whenever you are following up, whenever you are taking down or ingesting barium inside the oral cavity, first what we actually do is that we actually instruct the patient to hold out the barium inside the mouth. Then whenever the equipment got ready, what we actually ask the patient is to try to swallow to it, and we frequently monitor them in the video scope. Then what actually happens is that we'll try to get a video image first, and then finally we're looking at the images that are captured dynamically when the deglutition is happening, and we are getting down as a videotape or as a film. Okay, we will be getting film something over around like 6 to 7 images, because it takes something around like 3 seconds for the any kind of a food substance or any kind of water that is actually flowing down through the esophagus, oropharynx, from the oropharynx to reach down to the lower esophageal sphincter. Generally takes around like 3 seconds of time. So we will get series of images here, and this is the choice of diagnosing and documenting aspiration, okay, which is ingested substances passes into the trachea below the level of the vocal cords. Okay, so this is the choice of investigation for aspiration purposes. Okay, in most of the patients where we are suspecting aspiration pneumonitis, and reflux is this is actually happening because the lower esophageal sphincter is inconsistent or incompetent, that actually the food contents that are present down inside the stomach will actually rebound back into the esophagus and eventually passing down into the trachea, causing aspiration pneumonitis. So this is the choice of investigation. So biphasic examination or video esophagography is the choice of investigation for documenting aspiration. Okay. Now, look at here this image. It's a fairly it looks more like an X-ray, but follow one thing here is that you are not trying to look at the lung conditions. Okay, you are just trying to look at look at the esophageal motility, and you are trying to also look at the escape of food particles from the lower esophageal sphincter entering down into the trachea below the level of the vocal cords, okay, laryngeal folds. So in this image, actually, we see that there is a very high density, okay, a wide opacity that is present down in the right lower lobe. Understand one thing here, this is not pneumonia, okay? Pneumonia doesn't look like this. Pneumonia will actually have a hazy density. It will be much more of lower density than the barium contrast. Yes or no? So please do not, okay, or let us say if I have given only this image, please do not misdiagnose it as pneumonia, because pneumonia has got a fluid density, but this one is looking much more whiter than that. Yes or no? So please do not confuse it that way. And the material is a metallic density. So that is what you have to represent here. See, bones are much more whiter, but this one is looking much more whiter than the bones itself. So it became a metallic density and represents the barium that was aspirated into the lung during upper interintestinal series. So you have to understand this patient is not a lung problem, but it is actually happening because of the aspiration of the barium that has been ingested down from the esophagus, which eventually has to pass down into the stomach, but it did not pass into the stomach, but went back into the trachea and finally getting down into the right lower lobe. So this one actually indicates as the entry of the the barium inside the trachea is indicating that the patient is suffering from a condition called as aspiration. Okay, that's a very fairly simple diagnosis, but you can't actually say this one as pneumonia because you can represent it by the metallic density. Okay, it is looking much more whiter than the mnemonic consolidation or pacific, right? Yes, is this point clear here? Yes, no? Respond, guys. Okay, right. Then you see here, barium is generally an inert substance, but it does not cause any kind of additional symptoms that the patient was that already not having from aspirating his own secretions. So generally, the body over time, whenever the patient with aspiration kind of a problem, generally there will be a constant flow of the gastric intestinal secretions down into the trachea. So generally, even the barium is just very inert substance. Okay, it does not have any kind of drug effect, and it is just only that has to be excreted over time, right? But it does not cause any kind of an effect. It is an inert substance, so that's the reason it does not cause any kind of additional symptoms that the patient already was not facing. Okay, so fairly you can say this is a safe technique, but yes, obviously there will be some kind of a discomfort. It will take some time, but most of this barium will be reabsorbed, and most likely leaving only small amounts remaining back inside the whatever the area that has been aspirated. Okay, so no additional risk is there, but still there is discomfort. Yes, that is true, but it will take time to completely get reabsorbed. Finally, it will leave only some substance, only some remaining thing that is present down into the aspirated area. Okay, so first we are going to talk about different conditions like esophageal diverticula, esophageal carcinoma, and hiatal hernia, and gastroesophageal reflux disease. Okay, uh, it gets a little difficult here, so that's the reason I want you guys to pay a little attention. Fluoroscopic observation of the esophagus generally can reveal abnormalities in the esophageal motility. Okay, for example, to say the tertiary waves are common, but non-specific abnormality of the esophageal motility, representing the disorder and non-propulsive contractions of the esophagus. You have to understand that the esophagus is a peristaltic movement aided tract, which actually the main function of the esophagus is to redirect the food contents down into the stomach. Whenever you start to take down the food into the oral cavity, and when you swallow it, yes, it follows a three peristaltic movements at three different levels. Okay, we'll talk about that once in a short time, and they actually causes tertiary waves. Okay, because of the smooth muscle contractions there, and then when there is no non-specific abnormality of the esophageal motility is present, actually the final destination of that food particle or whatever the content that you have been taken down through mouth actually has to reach down into the stomach. But if that one is gone, if there is a problem inside the esophageal motility, for example, to say when you are talking about a disease called as achalasia cardia, okay, have you heard of this name one before? Achalasia cardia, or achalasia cardia? Okay, have you heard this name? No. Okay, we'll talk about it. Okay, we'll talk about it. And slowly over time, what actually happens is that there will be loss in the motility of the, you know, loss of motility in the esophagus. So there is a problem with the deglutition here. So over time, what actually happens is that, yes, it develops down as an abnormality and it can cause different types of pathological conditions, which is related only down to the esophagus motility. And now they can be observed fluoroscopically and captured on spot films. Okay, so main purpose of the fluoroscopic examination in relation to the esophagus is to observe the motility of the esophagus. Okay, now this is a very classical image. Remember this image. Okay, it is asked in most of the competitive examinations. uh, okay, before we get into it, okay, let me talk something about the esophagus, the properties of esophagus, so that you can actually understand the images that are coming over. Uh, just give me a second. I'll adjust my writing board. Okay, just. I think, is this chapter difficult? Yes, a little difficult, right? When compared to the previous. No, it's not difficult. That's the good news. All right. Okay. Can everybody see the blackboard? Yes. Okay. Right. Okay. So let's try to learn something basic anatomy that is related down to the esophagus. Okay. Pay attention. I think you already know these things, but if you don't know, maybe it is better time that we learn right now here. Okay. So generally, esophagus is a structure that is present down in the posterior mediastinum. Okay, it is present down in the posterior mediastinum, and its extension is from the C6 thoracic vertebrae to T11. Okay, extension is from C6 thoracic vertebrae to T11. Then we have the esophagus. The whole length of the esophagus is 25 centimeters from first cricoid cartilage. Okay. Okay. But the whole length of the esophagus is 40 centimeters when you are trying to analyze from the first incisor teeth. Okay. I think you know how we can actually differentiate between incisors and molars and other things, right? The whole length, okay, remember, this is a very important point, 25 centimeters from the first cricoid cartilage, and then it 40 centimeters from the first incisor teeth. So it means to say there is a difference. So how much is the difference between 40 and 25? 15 centimeters, right? So the extra 15 centimeters, that is the area you are actually calling it as the oropharynx and the nasopharynx, right? Okay, oropharynx along with the nasopharynx, and that is coming down and until to the level of the first cricoid cartilage. Yes, it is 15 centimeters. So ignoring the oral cavity and the oropharynx, okay, we are trying to generally look at the esophagus along this length. Okay, so but still we can also do as the length of the full 40 centimeters, so that doesn't technically matter. Right. Now, the esophagus has got three portions, okay? Three portions. You have to remember there are three portions of the esophagus. Let's try to get it like this, okay? Let's think this is the esophagus, okay? The three portions of the esophagus, the first part is actually called as the cervical part, okay? Cervical part of the esophagus. Then we have got the thoracic part, okay? Thoracic part of the esophagus. Then we have got the abdominal part of the esophagus, right? It has got three parts. Then, and here in the cervical part, actually the property of the, and there is trachea in behind, in front of it. So you have to see one thing here in the cervical part, the trachea is anterior to it. Trachea is anterior and present more to the left. Okay, so trachea is present more to the left. It is anterior and more to the left. You see here. So when we are trying to analyze on a chest X-ray, you can see a thick line like this, which is actually calling, we're looking at the cricoid cartilages that appears as a white line. But there is a very, very thin white line that is present just to the right of the trachea, which is actually your esophageal fold. I think you already knew about this before, right? So how we are recognizing and differentiating from the trachea and the esophagus is that this is appearing as a thick white line, the trachea, whereas the esophagus is appearing as a thin white line, right? And then here in the thoracic part also, yes, the trachea is anterior, okay, but it is present down here on the right, okay. So which means to say here at this level that the carinal angle has happened, so that's the reason now it became more towards the right, okay. Excuse me, I think I have lost the connection. Just give me a minute. Mm. Uh, okay, first let me continue. So this one became actually more towards the right here. And then the abdominal part, we have got the abdominal aorta in front of it, okay? Descending aorta pushes it more anterior and it becomes more to be left. Okay, so these are the three properties of the esophagus, okay? Yes, is this point clear? Have you learned this content before? If you learned about this one, yeah, I will actually completely skip off this one so that you will not actually, feel difficulty. If not, yes, I will start with the basic things, then we'll talk about the physiological movements, and then we'll finally get into the radiology content. Please confirm. Yes, no? What does this yes mean? It means to say you want me to teach this or you want me to skip off this and get down into the radiology thing? Please explain. Okay, okay, great. Okay, okay. Just give me a second. All right. Just a second, please. Uh, let's recall back once again. Okay, we have got three parts. Okay, we have got three parts of the esophagus. Okay, the cervical part. Okay, the cervical part. Then we have got the thoracic part. Okay, and then we have got the abdominal part. Now, so what we actually try to analyze here is the trachea is anterior, okay, and then it is more onto the left. Okay, trachea is onto the left. Okay, trachea is anterior and more to the left. Then here, where the trachea has already made down the carinal angle after below this level, what actually happens is that, okay, now the esophagus became more to the right, and so trachea became anterior and became more to the right. Okay, I'm talking about the trachea here. All right. And then in the abdominal part, okay, there will be descending aorta. Okay, there will be descending aorta that is coming, something like this. Okay, descending aorta. This is aorta. Okay, then it actually pushes it more anterior. Pushes which one? Pushes the esophagus more anterior here. So I'm talking about the esophagus. It pushes more anterior and more to the left. So generally, what we can actually see it here as a profile image is that the trachea came like esophagus came out like this, and then it went down into the stomach. The stomach is present down onto the left side, so that's the reason it became more to the left. Okay, so I think you can understand right now what I actually meant by here. I'm talking in relation to the trachea in these cervical and thoracic parts, but in the abdominal part, I'm talking it in relation to the aorta, which became esophagus, finally became anterior and finally became to the left. You have to remember it that way. So in the upper parts, esophagus is posterior in nature, yes, and in the lower parts, the the esophagus became more anterior. So is this point clear? Okay, this is simple anatomy that we know. Yes. Okay, is this clear here? Now, the same things you have to remember, these parts are the one, okay, the parts, the cervical part or the thoracic part and the abdominal part are the ones where the length is 25 centimeters. Okay, simple. Now, immediately after this one is actually became more left, and now it is opening down into the stomach. Okay, here is it became the lower esophageal sphincter. Very simple. Then the situation here is that you have to understand that however the food molecule comes down inside, okay, let us imagine that this is a food molecule, okay, food bolus you call it as, okay, this food bolus, when it is trying to enter down, these constrictions are actually happening at these levels itself, the cervical constriction, the thoracic constriction, and then the abdominal constriction, and passing on to the lower esophageal sphincter into the stomach. Simple. That is what the peristaltic movements are also happening. So there are 3 peristaltic locations. Okay. So I think last time I have told you how the peristaltic movements occur, right? Do you remember that one? Yes or no? Yes. The distal part is actually being distended where it collects the food bolus, and then the proximal part constricts. Then finally, the distal part constricts and the proximal parts opens up. So it drives the food particle inside the hollow tube. Yes or no? So that is what we learned in the previous classes. Right now, that is the same thing that is happening. But most of the times you have to understand one thing. The particles that are actually entering from the oropharynx into the cervical region, until that process is actually called as deglutition. Okay, the thing that is actually happening, the driving of the food from the oropharynx to the cervical part of the esophagus is called as deglutition. Deglutition is nothing but swallowing. Okay, but after from cervical region to the what do you say, entering down into the lower esophageal sphincter, the whole process is nothing but effect of gravity. But still, the constrictions has to happen. The peristaltic movements has to happen. It doesn't necessarily mean to say that, yes, without there is a peristaltic movement, the food directly passes down from the gravitation. No, it's not like that. But constrictions happens, but most of the times the effect is actually taken out by the gravity. But until it reaches from the oropharynx to the cervical part, yes, it is called as deglutition, which gravity has nothing to do with it. It is actually done by the muscles of mastication, and then muscles of the mastication make out a food bolus as a circular ball, and then the ball is pushed down into the oropharynx, and then the ball is pushing down further into the the cervical parts of the esophagus. From the cervical parts, yes, the effect of the gravity is taking place, but still peristaltic movements aids the food passing down into the abdominal, thoracic and abdominal parts, and finally entering down into the stomach. So is this point again clear? Okay, that is what you need to remember here. Now, why I actually have to tell you all these things? Let us imagine a patient who has a problem of swallowing. Okay, and the problem of swallowing is generally called as dysphagia. Okay, the problem is actually called as dysphagia. Okay, there is pain during, let us say this is pain during swallowing. Okay, or difficulty in difficulty. Let us technically say difficulty. There is, you need not confuse here. Okay, difficulty in swallowing. Difficulty in swallowing or during swallowing is actually called as dysphagia. Okay, then there is another condition that is actually called as odynophagia. Okay, odynophagia is means to say pain during swallowing. Okay, there is technically, most of the patients generally they are unable to differentiate between dysphagia and odynophagia. Okay, but still, let's not get into the particular details how to differentiate between dysphagia and odynophagia, but let us try to understand what exactly they are. See, uh, dysphagia and odynophagia generally has to be dependent upon the type of food content that you are actually degluting. Okay, the type of the food you are trying to swallow down is the one that actually determines the severity, if there is any difficulty in swallowing or if there is any pain during swallowing. Now, let me ask you a simple question. Okay, how many of you people usually have had this problem of dysphagia? How many of you people had difficulty in swallowing before? Anybody? Okay, whoever thought sometimes, sir, it is very, very difficult for me to swallow things. The food is not even entering inside my, inside my stomach. So how many of you people feel that one? Answer, guys. Have you ever experienced difficulty in swallowing? No? Yes? Okay, Jerry seems to having this problem. Okay, so Jerry, tell me, what do you think? Why is this happening? Is this happening because of a problem in the esophagus, or is it happening a problem of something else? Do you think that you have a problem with your esophagus? Tonsillitis. See, most of the content, yeah, maybe something. Of course, it is something. If not, you will not be having any kind of symptom. Obviously, you see here, the patient will be actually telling you a different story. A real problem inside the esophagus, the patient will come down with a new story. So, what actually, yes, Aman, yes, you are correct some way. Okay. Well, there is, difficulty when there is a dry mouth and when there is not enough lubrication, or when the food bolus is so much bigger, or sometimes yes, bacterial infections. Yes, there are millions of reasons, but still we cannot really point out that a problem is happening down in the esophagus. But if you wanted to define difficulty in swallowing, which is dysphagia, and pain during swallowing, that is odynophagia, we have to look for a very peculiar pattern inside the patient. Now remember, we will use the same kind of technique inside doing the fluoroscopy. The thing is that difficulty to liquids, difficulty to solids. Okay, these are food particles, obviously. Okay, difficulty in taking down liquids. Okay, now let us imagine a patient comes down to you and says that, okay, I have a difficulty when I am taking water. I have a difficulty, uh, I have a difficulty when I am taking some kind of a fruit juice. So liquid generally has to pass down due to the effect of gravitation immediately after it leaves down the cervical part. Yes or no? So now the liquid will eventually pass down into the lower esophagus without any kind of a difficulty, right? So there should be no kind of a problem. Neha Yadav, why can't I find you? Just give me a second. There are 54 people. Where? Neha, I cannot see your name. Oh, yeah, here. No, you are already in the group. Neha is already in the group. Is it? Where is Neha? Okay. All right. Okay. Right. So now a patient complaining of a dysphagia to the liquids. So obviously now you tell me one thing. Why, if the fluids have been going down inside the esophagus with the effect of the gravity, which are technically much more easier to pass down, okay, why do you think that the patient will be complaining of this one? Okay, take a guess. Try to analyze the situation and tell me why the patient must be complaining that there is also difficulty to the liquids. Obstruction. Perfect answer. Okay, then now let us say a patient is actually complaining only difficult to solids. Then forget about the patient has already swallowed the content. Okay, the patient has already swallowed the content, so saliva doesn't actually play a very important role here. Okay. See, difficulty into liquids and solids can be happening because of an obstruction somewhere, but difficulty to only solids can be happening because of the peristaltic movement. Because unless the peristalsis is happening, the solid food cannot be passed down, right? But difficulty in the liquids is actually also says that there is some kind of a problem that is related to the obstruction first thing, and it is also there's some kind of a problem with the deep mucosal layers as well. Okay, so let us say when you are trying to flush out, okay, when you are trying to flush a the sink hole, okay, if it has got an obstruction, you will be actually driving a more amount of water to it, right? When you are trying to flush it, the same thing is happening inside the esophagus as well. Okay, unless there is a lot of force. Now let us imagine that there is some kind of a problem inside this tubing that is inside your sink. Now what happens, even if you flush, because of the crookedness that is present down inside the tube, what happens, sometimes the food particles get stuck over this place, right? Yes or no? So now this one, when it's trying to drive with a lot of force, and when the peristaltis is added to it one, but actually it causes a lot of irritation. So that can be happening because of the difficult to liquids as well. So any kind of a problem inside the erosions of the mucosal folds will actually have the difficulty to liquids, and anything that is related down to the peristaltic movements will have both difficulty of liquids and solids as well. Okay, and the most important conditions, that is what the whole theory is dependent on this one. So forget about the pain during swallowing or odynophagia or dysphagia, doesn't matter. However, the patient comes over. We are technically not worried about anything. Yes, if there is, yes, of course, if there is obstruction to the liquid, yes, it ought to cause a problem with the swallowing solids also. Yes, that is true. That is true. So rather than trying to analyze and differentiate it clinically, we will try to analyze it, we will try to analyze it in a different way. But that is the reason why we are utilizing the fluoroscopic studies here. So in such kind of a situation, we will try to look at one thing. The first immediate disease, it is quite easy to understand, is at this particular image here, okay, and see here that the esophagus constrictions has to happen at three locations. But you see here, there seems to be a bearded appearance, okay? It seems to be a bearded appearance all over in the lower parts of the esophagus. You see here, this is the abdominal part of the esophagus, because I can see the diaphragmatic shadow around here. So this is the lower part, this is the abdominal part of the esophagus. Now, what I actually am trying to look at this patient here, I have a peculiar peristaltic movement. There are only three peristaltic contractions that are happening in the esophagus, but look at this one, it is having so many peristalsis when it's compared to the other. Yes, a normal person will not have this aggravated peristaltic movement, and it is actually causing because of the tertiary waves. And this is actually happening because of a clinical condition called as diffuse esophageal spasm. Okay, remember, it is also called as DES. Remember, it is a very, very classical disease. It is a very classical appearance, which actually shows you the appearance of a corkscrew esophagus. Corkscrew esophagus is nothing but, okay, if you the same kind of a screw that you actually use to open down the wine bottles, right? There is some kind of a corking. Cork is the one that is actually present down on the wine bottle, okay, which is made up of wood, and you use some kind of a metallic cork screw to insert into it, and then try to remove it from the wine bottle, right? That's the same way how this esophagus is looking. Yes or no? You see here, there is a pointed appearance here, and there is a lot of rotations here. So that is what actually happens because of the esophageal increased motility of the esophagus in the lower parts and in the abdominal location particularly. And we call this condition as DES, which is nothing but your diffuse esophageal spasm. Okay, so corkscrew appearing esophagus is a classical feature of diffuse esophageal spasm, and it is actually happening because of the non-propulsive of contraction of the esophagus, which is called as the tertiary waves. So we see here the waves appearing here, so which actually gives it a screw-like appearance. Okay, remember, this is a very classical picture. It is asked in most of the examinations. Okay, right? So tertiary waves, why actually they are happening is that the tertiary waves are non-specific and very common abnormality that increases with the advancing age. The most important risk factor is the advancing age. Now, what actually happens is that the patient will obviously complain of odynophagia, will obviously confirm dysphagia to liquids as well, but still they will be relieved after some time. So which means to say, slowly and slowly after these tertiary waves are ended, yes, finally the food particle enters down into the lower esophageal sphincter. It remember, in this disease, in most of the diseases, the food cannot get stuck inside the esophagus. The destination where the stomach is actually getting its contents. So that is the only key point you have to remember. So which means to say, you have to ask the patient, does he have a normal bowel habit? Yes, the patient will have a normal bowel habit here. But let us say if the patient's food did not even enter down into the esophagus, entered down into the esophagus, but did not reach down into the stomach, which means to say the process of digestion never happened. So what kind of a condition will actually cause the food to get stuck inside? If there is a severe obstruction down in the esophagus, yes or no? Food particles doesn't even enter inside it. So as a result, the patient will be anorexic. The patient will have they will have there will be no loss of appetite, but the patient cannot just consume foods. And yes, the patient is obviously hungry, but still the food doesn't enter inside the stomach. So now what kind of a condition could usually cause this kind of a situation? Yes, there is a complete severe obstruction down to the esophagus where the food particle is being taken down inside, but it does not enter the stomach. For example, to like carcinoma. Or let us say the complete motility of the esophagus is gone, okay, which is, we call it as a motility disorder, which might be happening because of achalasia cardiac condition. Okay, loss of motility or loss of contractions ability in the esophagus is actually called as achalasia cardiac, which eventually also will have this kind of a problem. Okay, rather than observing it clinically, you try to understand the situation. Okay, and we are basing on the symptoms itself, we are trying to make a conclusion what kind of a problem could it be, and just we are trying to do fluoroscopy to examine and confirm that condition if it is present or not. Okay, in that one, first we learned about the diffuse esophageal spasm. Diffuse esophageal spasm, okay, diffuse esophageal spasm is a condition where there will be tertiary waves. Okay. Now, the next important condition we are going to talk about the esophageal diverticula. Okay. Esophageal diverticula is fairly a very easy diagnosis to make. Okay. A fairly easy diagnosis. Diverticula of the GI tract is usually produced when the mucosal or the submucosal layers herniate through the defect in the muscular layers of the bowel wall. Okay, diverticula is a condition where there will be, where there will be a problem inside the mucosal and submucosal layers that herniate through the muscular wall. All right, so now let me get you a simple condition what actually happens. All right. Mm, just give me a minute. Okay, now let's try to understand, and then the radiographic features are quite easy in this one, but let us try to actually see what exactly is an esophagus diverticula here. The first thing that we actually need to understand here, um, I'm not really so sure that you will be able to answer this question, but I think you must have already learned. Can somebody tell me what are the muscles of the neck? Muscles along the trachea and the esophagus? Do you remember them? Yes. Okay, sternocleidomastoid is the muscle of the neck, but does it have any kind of a relation that has to do with the esophagus? Now, I'm particularly talking about the laryngeal muscles, okay? Okay, fine. I guess maybe you cannot trapezius now. Okay, let me make it easy for you. Okay, yes, thyroid muscles. Okay, then more. Come, more names. Cricoid. Okay, next more. Arytenoids, sternohyoid. More. Homohyoid. Man, you're talking about all the bone names. Don't tell me bone names. Hyoid or homohyoid, yes, that is a muscle. Yeah, but still. Digastric, cricothyroid. Okay, then more. Yes, lateral carotenoid. Yes, more. Then okay, fine. So I think you know about those muscles, right? Okay. That's fine. That's fine. Yes, you know the muscle names. Okay. The problem of the diverticula is something like this. Remember, listen carefully. Okay. Diverticula is the one that is actually causing an outpouching of the esophagus. The esophagus that has to be present something like this. Now, what actually happens is that it became a package. Okay, it became a package and it became an outpouching. Okay, outpouching. Now, you see here, the whole layers of the esophagus have been involved into it, this one, right? So it is not a problem of erosion. It is actually a problem of the muscle. Now, what exactly is this problem? Why do we have a diverticula? Is that is something like this. You know the muscles, okay, there are three muscles along that lines along the esophagus. This is the inferior pharyngeal constrictor and then thyropharyngeus muscle, okay, thyropharyngeus muscle and cricopharyngeus muscle, okay. Now, there is a sensitive area in between these muscles, okay, which is actually called as a space, okay. This is actually called as a, you know, a weakest area along these three muscles, okay. What are these muscles? Inferior pharyngeal constrictor, okay, constrictor muscles, okay, inferior pharyngeal constrictor muscles, okay. These muscles, what are they? It is the thyropharyngeus, okay, thyropharyngeus and cricopharyngeus muscles, okay. There is a mucosal layer that is actually present in between them, which is actually the weakest part, and that weakest part is actually called as Killians Dehiscence, okay. Killians Dehiscence, remember, okay, it is actually called as Killians Dehiscence, okay. Did you understand? Okay, let me show you anatomically that image so that you can actually understand very clearly what exactly is this Killians Dehiscence. Okay, Killians Dehiscence. All right. Okay, look at the image I have sent you down in the chat. Okay, there is a thing, okay, you can actually see that there are two muscles, okay, which is the thyropharyngeus and the cricopharyngeus. Thyropharyngeus is the oblique muscle and the cricopharyngeus muscle is the horizontal muscle. And immediately we have the inner circular fibers of the esophagus and outer longitudinal fibers of the esophagus. Can you see it? All this people? Can you see the image? Did you open it? Right? Okay, you see here, there is an oblique muscle as the thyropharyngeus muscle and the horizontal muscle as the cricopharyngeus muscle. Then we have the circular fibers of the esophagus and outer longitudinal fibers of the esophagus. And you see here, there is a triangular area that is actually formed in between the junction of all these muscles. Now, this one is actually called as the Killians Dehiscence. Okay, Killians Dehiscence is the weakest part of the esophageal area. Okay, of these muscles, in between that muscles, where the esophagus is more liable to form an outpouching. So, diverticulum, the most common location of the diverticulum, actually happens in the Killians Dehiscence. You will learn about this one in surgery again, but I think it is better you try to understand it here itself. Okay, so now look at another image in the chat I sent you. Okay, look at this another image. In this image, what we actually try to see here, okay, what we actually try to see here is that you see here there is this hyoid bone, and then there is this the cricoid cartilages, and then we have the thyropharyngeus muscle, and then the cricopharyngeus muscle. And we came to understand that there is this Killians Dehiscence that is present in between them. And what is the nerve that is actually supplying them is to the external laryngeal nerve, that is the one that supplies to this one, right? And recurrent laryngeal nerve is also one that is supplying to the cricopharyngeus. Okay, right? Yes, right? Then there is in this where there's a small part where there is some kind of a weakest point, actually it started to form an outpouch through the Killians Dehiscence. So this is the diverticula. All right, so this is the most common location of the diverticula, and such kind of diverticula is actually called as a Zenker's diverticulum. Okay, Zenker's diverticulum. Remember the name, okay? It is called as a Zenker's diverticulum. Now, the patient actually complains of dysphagia. Obviously, there will be a painful, swallowing, difficulty in swallowing. Then what actually also happens is that the peristaltic movements is trying to happen down even in this location, right? Because of the continuous nerve supply. Then the patient will eventually something that actually enters down into these parts as well, right? The something, okay, whenever your food is entering from above, okay, when the food is trying to enter from above, it is also trying to get down and stay down here also, right? So now let us say if I have taken down a liquid, okay, the liquid slowly and slowly comes down and forms over this diverticulum as well, right? Fills in the diverticulum as well. So whenever a fluid is actually filling out in a bag, you will hear a sensation, sorry, you will hear a sound that is actually called as gurgling. Yes or no? So gurgling sensation is the one that actually the patient complains, and that gurgling sensation is actually happening inside the neck. So he says that I literally hear gurgling sensations down inside my neck. And yes, there is dysphagia. And also remember one thing, right now this food is getting stayed down in this place itself. It is not entering the stomach, right? So most of the food, undigested, chewed food is being present down here. So what eventually it becomes completely rotten. Okay, if there is a rotten food that is present down inside the, this pouch, what actually happens? It causes bad breath. Yes or no? Right? It causes bad breath, and what do we call that condition? As a halitosis. Okay, a new symptom. I think you haven't heard this kind of symptoms till today. Okay, it is actually called as halitosis. Halitosis means to say there is a bad breath. Okay, so now the whole problem is present down here itself. Okay, there is a weakest part that is present down between the thyropharyngeus muscle and the cricopharyngeus muscle, and there is an outpouching that is actually formed through the weakest area, which is called as the Killians Dehiscence. Now there is called as a Zenker's diverticulum. All right. So now Zenker's diverticulum, what actually happens is that there will be pulsatile sensations here and also traction sensations here, and there will be gurgling, there will be dysphagia, and also because of the stagnation of the food particles in this particular pouch, what actually happens is that there will be halitosis, bad breath. Okay, right? Eventually, all the food has to be digested. Now, over and over time, the food stays here and it becomes rotten, and it becomes it. That is the reason why the patient will have, you know, what do you say, halitosis. And why is this condition actually happening? Is it is because of the neuromuscular incoordination. If there is a problem that is actually happening between the external laryngeal nerve and the recurrent laryngeal nerve, if the patient actually underwent down a surgery of parathyroid, resection, or actually the patient actually went down to a surgery that is related down to the goiter or thyroid carcinoma. The most important nerve that actually that tries to get injured first is this recurrent laryngeal nerve. Okay. Yes, infection will eventually develop. It actually depends on the amount of the food that is entering down into the diverticulum, and also depending upon the size of the diverticulum. Okay, diverticulums generally, develops over time. The size of the diverticulum actually increases over time, and the patient will be complaining of dysphagia and gurgling sensation only when the biggest pouch has already formed. Until then, no halitosis, no gurgling sensation. The patient will be complaining of constant dysphagia and dysphagia. Did you understand? So most of the patients will eventually be recognized only when there is a bigger pouch that has already been formed. Okay? Yes, I think the concept of the disease is right. Now let's try to get down the investigation of choice that is related down to the confirmation of the diverticula of the esophagus is nothing but your barium study. Okay, upper GI tract barium study. And what actually happens is that you see here in the neck, the diverticulum is posteriorly located. If it is posteriorly located, we call it as this Zenker's diverticulum, and it is actually happening in between the Killians Dehiscence, cricopharyngeus muscle and thyropharyngeus muscles in the superior, right? Then diverticula at the level of the carina may be caused due to external inflammatory disease such as tuberculosis, which is also called as the traction diverticula. There are different types of diverticula. Okay, we need not worry about this one. Now you have to understand that there are two types of diverticula: true diverticula and a false diverticula. You will eventually learn them in the surgical topic, but I will not get down into much more details of that pathophysiology is there. But just remember the names, though it happen. Diverticula just about the gastroesophagic junction can also happen, which is actually called as the epiphrenic diverticula. Okay, so there are different types of diverticula at different locations. Okay, the locations most commonly are pharyngoesophageal. Okay, pharyngoesophageal, then parabronchial. Okay, parabronchial, which is actually happening because of tuberculosis, or then it is actually happening also epiphrenic. Okay, epiphrenic sites. Okay, these are the three common sites where the diverticula can happen. But doesn't matter which place the diverticula happened. Okay, only if it is happening along the level of the Killians Dehiscence, it is called as a Zenker's diverticulum. Okay, that is the one you have to remember here. Okay, it is actually happening between the oblique thyropharyngeus muscles and the longitudinal cricopharyngeus muscle. It's the weakest part inside the the esophageal, the cervical area. So that is the one that is actually called as the Zenker's diverticulum. This is the one would you have to mostly remember. But doesn't matter wherever the diverticula is present, it is actually showing up as the filling up of the barium. Now, barium is technically used as a contrast material. Okay, it is radially active, radioactive substance. And right now, just as the way how the food enters down into this outpouching, that's the way also the barium also can enter down into this food pouching. So it will start filling up and it will light up as a light bulb. You see here, there is translucency that is present on the top, and there is hyperdensity that is present on the below. So it is a light bulb appearance, okay? And right now, that is a direct evidence, and you can see here, this is actually, this is not seen, this is seen as the collection of the barium material, which is shown as a bag-like structure, okay? And now it is shining up as a light bulb, okay? You can also call this as the bulb sign, or you can also call it as, outpouching collection of the barium inside the uh, diverticula. So that is the only direct diagnosis. See, the condition is difficult to diagnose clinically, but on the radiological, you see here how simple it is. So that's the reason investigation of choice for an esophageal diverticula is the barium swallow technique. Okay, barium swallow is the investigation of choice. And the diagnosis here, what you are looking is this Zenker's diverticula. All right. Yes. Easy, I guess, right? The diagnosis of the picture is quite catchy here. Picture is quite easy to understand. You see here, you see as an outpouch, there is a balloon here, and then there is a translucency above, and there is a hyperdensity in below. So this indicates that the collection of the fluid inside the diverticulum. So which obviously tells me I'm looking down in the cervical region of the esophagus, where it is the location of in between the thyropharyngeus muscle and the cricopharyngeus muscles. So that is the weakest part, that is called as the Killians Dehiscence, and there is an outpouching here. So that's the reason I made by diagnosis that is called as the Zenker's diverticula. Simple. Is this clear? Yes? Yes, no? Right? It's fairly a simple things. You need not worry if it's a true diverticulum or a false diverticulum. Don't worry about such things. You will be learning back again in surgery. But for radiological purposes, no, we'll not be doing that one. All right. No, you see, it actually depends upon the amount of dehiscence. The dehiscence, the weakest part, depending upon the you see here, depending upon the layers that are involved inside the diverticulum, either it becomes the same difference like what you have learned in the aortic aneurysm and the aortic dissection. Do you remember that theory there? Okay, the number of layers that are involved is the one that is actually determines the size of the aneurysm. Yes, right? That's the same thing like here too. Okay, so that is how we are classifying them as true or false diverticulum. Okay, you will learn about more in surgery department, but let us not worry about them here. Okay, because it is completely much detailed. You will learn about this one in so much detail in surgery. Okay, now you see here there is another diverticulum that is happening down along the mid esophagus. I can clearly see here that there is entry of the entry of the barium inside the outpouching, and I can see this shape of the outpouching here very clearly. And it is actually happening because of the extrinsic disease, which is also because of the tuberculosis, which is actually called as the traction diverticulum. Okay, it is the traction diverticulum. Like I said, it is a problem of pulsion and it is a problem of traction. So remember, traction diverticula is caused by which one? Tuberculosis. Okay, right. And then just above the diaphragm, if there is an outpouching and it is happening, and it is, remember, this is a problem of esophagus. This is a problem of esophagus, and we are calling diverticula if it is happening in the esophagus. And if it is happening just above the level of the diaphragm in the abdominal part of the esophagus, we call it as the epiphrenic diverticulum. Which one you see here? That is also fairly the simple thing. It's okay, there is a collection, a lot of barium that is present down through this weakest part that is coming down here, and this is the only true verticulum that is involved, okay, in the esophagus. The whole, all other esophageal diverticulum are called as the false diverticulum, but the epiphrenic diverticulum is only the one that is actually called as the true type, and this is also one of the most common types of diverticulum that happens. All right. But you won't be asked down a question, okay, which is the most common type of diverticulum, particularly in radiology. You will be asked image-based questions. Okay, remember these three images: traction diverticulum here, or the esophageal epiphrenic diverticulum, or the Zenker's diverticulum, which is happening because of the Killians Dehiscence. So the question completely might be, indirect here. Okay, let us say I say that, okay, here I am showing up a Zenker's diverticulum. The problem is present down inside is the cervical part, thoracic part, or the abdominal part, something like that. Or I can show you this one is happening. This is Zenker's diverticulum. The muscles that are involved are cricopharyngeus and thyropharyngeus. Okay, the weakest part that is present between the thyropharyngeus and cricopharyngeus is Killians Dehiscence. So the questions won't be direct. Based on the image, you will be asked down a lot of clinical questions. So that's the reason, make sure that you learn this chapter very, very well. And you might also have an essay question from this chapter as well. Okay, so that's the reason I'm taking time to teach this one very, very slowly. There is a lot of theory to grasp here. All right, so traction diverticulum happens because of tuberculosis. It may is happening down in the parabronchial area, and it is present down also in the thoracic segment of the esophagus. If it is happening in the distal parts of the esophagus, well, yes, any kind of a diverticulum usually will eventually cause halitosis. But you see here, sometimes some people will have very, very strong breath, bad breath. Sometimes some people do not have. It actually depends on the amount. Halitosis actually depends on the amount of food that is present, time of rotting of the food. Yes, it can be present. And logically speaking, you see here, anything that is present inside the stomach, you can't even smell by yourself. Now, let us say if the distal part of the esophagus has been ruptured and has been present, and the diverticula is present there, it literally, generally that kind of a smell will not be perceived by the doctor, but the smell can be eventually perceived by the patient itself. The patient usually complains, I smell myself very bad. I always smell the vomit. Okay, if you always smell the vomit, yes, it could be happening due to a diverticulum. Yes, did you understand? So there is a difference of what the doctor observes, and there is a difference what the patient observes. So, so that's the reason you cannot really determine halitosis to be a very deterministic factor to make up a diagnosis of, diverticulum. But generally, yes, it comes down as a classical triad, because all the diverticulum comes down eventually when they have become so much big. Until then, the patient will be generally asymptomatic. So what are the common things that present down into the diverticulum? It is dysphagia, gurgling sensation inside the neck, okay, and then halitosis is the three classical features. So is this clear, Benedict? It is dependent. So that's the reason you need not worry about the clinical diagnosis. But whenever you are suspecting some kinds of things, see, not only we don't only do the barium swallow, not only for the diverticulum, we do for evaluation on a whole. We are trying to look at the erosions, we are trying to look at the obstructions, we are trying to look at the outpouchings, we are trying to look at the constrictions, we are trying to look at the motility problems all together. So which means to say one set of fluoroscopic image will give you a differential diagnosis of something around like 20 to 30 diseases. So it's a good investigation. So based only on the image, you are trying to make out a diagnosis here. You do not expect to make a diagnosis beforehand here based on the clinical scenario. That's fine. Don't worry about that, but you will eventually learn these things. Okay, esophageal diverticula or the Zenkel diverticula are the false diverticula because of the mucosa and the submucosa herniate through the defect in the muscular layer. Okay, that's what we were talking about. It is called as the Killians Dehiscence. So that's the reason in the Zenker's diverticulum is called as a pseudo diverticula. It is not a true diverticulum, but it is actually happening because of the weakest part in the esophagus. So both the layers, the muscular layers and the submucosal layers, both of them are involved in it. But in the other diverticulum, no, it's only the submucosal layers that has been involved in it. All right. So that's the reason why we call the Zenker's diverticulum as the pseudo diverticulum itself. All right. Okay. Now let's get into a very, very classical condition that is actually called as the esophageal carcinoma. Okay. Esophageal carcinoma. I think it's better we try to understand about. Just wait. We'll try to understand about the esophageal reflex first, and then we'll come down to the the condition of esophageal carcinoma. Okay, let me explain what exactly happens in other condition. Okay, have you ever heard of a condition that is called as GERD, gastric disease? Yes, no? I think most people know about this. GERD is fairly a very, very common condition that we know about it. So now you are the guys who should actually answer me. I think you know a lot about GERD because you already started to learn about it in the pharmacology itself. Okay, so tell me, somebody tell me what is GERD? GERD, what is the full form? GERD, GERD. Okay, GERD is nothing but gastroesophageal, okay, esophageal reflux disease. Okay, fair enough. Esophageal reflux disease. All right. Now, what actually happens in that one? Before we try to get down into this one, we will try to look, uh, why this one actually happens. Okay, anybody has an idea why what happens in this one? What happens in this condition? Okay, Aman, can you take a guess? You have been, very sensitive to saliva before. Disturbance in the lower esophageal sphincter, acid bile. Well, okay, right. See here, the problem is also no. Actually, why I said that? Okay, you have been, a lot. You were talking about saliva a lot before. So, can you tell me what is its relation? Do you think that saliva has got something to do in relation to GERD? That's what my question was. Okay. Now, okay, while you think about that, let me complete the other things. The esophageal gastric esophageal reflux disease is actually also known as a condition that is called as the water brush. Okay, and it is also known as heartburn. Okay, and it is called as this way because it is the most common cause of chest pain. Okay, related to esophagus. Related to esophagus. And also you can classically say it this way, it is also one of the most common cause that is not related to heart. Okay, so a burning sensation that is happening along the region of heart. That's the reason we call it as heartburn. We call it as water brush as well. Okay, water brush, H. Okay, it is actually one of the most common cause of chest pain related to esophagus. So the pain actually is retrosternal. Okay, remember the pain is retrosternal chest pain, where there will be persistent, there will be occasional, intermittent, pain that is actually coming down, which has got something related down to food intake. Okay, now, yes, Aman, did you think about it? Okay, so actually the most important reason for this condition is that there will be, okay, I think, yeah, there will be, causing of, excessive relaxation, okay, excessive relaxation, of the lower esophageal sphincter. All right, there will be excessive relaxation of the lower esophageal sphincter, which eventually causes excessive reflux of the gastric acid into the stomach, into the esophagus. Excessive reflux of the gastric acid inside the esophagus. So incompetent lower esophageal sphincter and releases of the gastric acid inside the esophagus. Now, there is also another condition, what we call it as the water brush alternatively. So what we learn about the water brush here is it has got something not only due to, you see here, not only due to lower esophageal sphincter, but also that is related down to saliva. Okay. Now, have you ever heard of a symptom that is called as pyrosis? Yes? No? Have you heard this term before? Pyrosis? Okay, right? Remember what actually is pyrosis is excessive, okay, reflux, excessive reflux of salivation. Well, what is the nerve that controls saliva? Salivation. What is the nerve? What is the thing that actually causes secretions from the glands? Vagus. Perfect. Okay. Excessive vagal stimulation will eventually lead down to water brush. Okay. Water brush, excessive salivation that is actually happening because of vagal reflex is called as the water brush. And yes, which is also one of the most common condition that is associated with GERD, not only because of the lower esophageal lower esophageal incompetency, but it is also happening because of the excessive salivation that is related to vagus nerve. Now, tell me, have you ever heard of, maybe I think I will give it as a fact rather than asking as a question. Progesterone also, increases lower esophageal motility. Okay, progesterone, the hormone, female hormone, is also increasing the lower esophageal motility. Okay, so in pregnancy, progesterone, generally the levels of the progesterone are increased. So GERD is a most common condition that might be coming down in pregnant women as well. Interesting. This is a peculiar thing that you actually happens. So who are the people that actually complains? Is that okay? Who the people inside the pregnancy, old age people, all of them who has got the incompetent lower esophageal sphincter are the one that actually complains. So what do they actually complain here? They actually complain more of dysphagia. Okay, more of dysphagia. Now, what actually happens here is that GERD eventually is the reason to another condition that is also known as Barrett's esophagus. Barrett's esophagus. Okay, a condition called as Barrett's esophagus. Now, can somebody tell me what is Barrett's esophagus? What is Barrett's esophagus? Okay. See, out of all these people, okay, that's great. Now people are talking. Why did you recall the message? That's the correct answer. All right. See, Barrett's esophagus is a condition. Okay, now you see here. Let's try to understand what actually happens in this disease. You see here, a constant exposure of the gastric acid is happening down into the esophagus. Yes or no? See, here is the stomach. Here is the gastric acid, right? Gastric acid is present here, right? And there is a constant exposure of the gastric acid in the lower parts of the esophagus. Now you see here, there is a thing that is actually called as the Z line. Okay, uh, I don't know if your anatomical teacher has taught you about this one. There, okay. Now the stomach is actually lined by columnar epithelium, where here it is actually by squamous epithelium here. So now what actually happens is the squamous epithelium that is lining the esophagus, and there is a columnar epithelium that is actually lining the stomach. Now, after constant exposure of the gastric acid into the esophagus, what actually happens is that this squamous epithelium eventually becomes columnar epithelium. But there is a line here which is actually called as the Z line. Okay, there is a thing that is actually called as the Z line, which is also called as the Z columnar line. Okay, Z columnar line, where there will be the squamous epithelium above and the columnar epithelium below. Now what actually happens is that there it will slowly and slowly, this squamous is present upper, okay, and columnar is present lower. So this one eventually will be gone. Right now the whole things will eventually becomes columnar epithelium. So that is what your condition is called as the Barrett's esophagus. Okay, a constant change of a metaplastic change, a constant metaplastic change that is actually happening down to the squamous epithelium of the esophagus, converting down into the columnar epithelium due to the secretion, excessive secretion or increased exposure to the gastric acid due to the incompetence of the lower esophageal sphincter is nothing but your GERD and Barrett's esophagus. So, what is the risk of Barrett's esophagus? GERD itself. So, the patient initially presents up with GERD, and then, which means to say the patient eventually develops down into Barrett's esophagus. Now, let me ask you one question. If you understand this concept, the next diagnosis of radiology is quite easy. Now, let me tell you one thing. GERD is a risk factor that is related down to the Barrett's esophagus. Barrett's esophagus is changing of the columnar epithelium, the change of squamous epithelium into columnar epithelium, which is metaplasia. Now, let us say if more and more acid is still being secreted down to this columnar epithelium, which is already formed down in the Barrett's esophagus, what will it eventually lead down to? Overstimulation again happening down into the columnar epithelium that has already plus dysplasia and cancer. Now you tell me, what is the most important reason for esophageal carcinoma? Isn't it eventually GERD? Yes or no? Right? So that's what it is. All these conditions are interrelated. So which means to say we are trying to expect all the radiographic features as a mixture. We are trying to see it, okay, Barrett's esophagus as some condition, GERD as some condition, and esophageal as some condition. You need not technically learn it that way. They are all interrelated together. So which means to say this is eventually a progression. So do not learn GERD and Barrett's esophagus and esophageal carcinoma as three different diseases. You will be confusing yourselves. So rather than learn it as a single set. Okay, esophageal carcinoma. But here you have to understand one thing here. Let's try to understand the logic here. One thing that I have told you that the squamous epithelium is converting down into the columnar epithelium. So If the columnar epithelium that has been formed down in the Barrett's esophagus, okay, is getting more irritated, it is causing esophageal carcinoma. Yes or no? So anything that is causing down in the same cell lineage, what kind of a carcinoma will it cause? What kind of a carcinoma will it cause? The simple answer is nothing but your adenocarcinoma. If you do not understand what exactly is an adenocarcinoma before, try to understand here now. See here, doesn't matter wherever in the body, if it is happening, the dysplastic change happening, or the excessive neoplastic stimulus that is happening down to the same cell lineage and becoming much more and much more neoplastic due to the constant stimulus or teratogenic effect, is actually called as an adenocarcinoma. But now let us try to understand. Let us say that there is no GERD that is present. Okay, let us say that the patient did not have or eventually developed down into the Barrett's esophagus condition, but still the patient complains of dysphagia and still the patient has got a carcinoma. What could that carcinoma have been? Look at this logic and just tell. The answer lies quite here. Did you understand my question? See, the patient has no GERD, the patient has no Barrett's esophagus, but still I got a diagnosis of esophageal carcinoma. What kind of a carcinoma could it have been? Well, the answer lies itself here. The answer is nothing but your squamous cell carcinoma. Perfect. See, did you understand now how simple it is? We might be confusing, okay, well, I don't know what exactly is an adenocarcinoma before, squamous cell carcinoma before. Right now, it is quite simple. You see here, there is a constant exposure of the gastric acid to the squamous epithelium in the esophagus. So that's the reason they were converted down into the columnar epithelium. I call that condition as Barrett's esophagus. Constant exposure is happening, I call it as GERD. When this columnar epithelium is eventually being more and more irritated by the gastric acid, yes, it is eventually forming a neoplastic change. It is actually forming a dysplasia into it, and that one actually leading down to adenocarcinoma. And it is eventually leading down to squamous cell carcinoma. If it is not involved, it is leading down to squamous cell carcinoma. If it is involved, it is causing the adenocarcinoma. Now, let me ask you again, a simple logical question, and I think you should be able to answer this one so fast. Okay, what is the most common type of cancer that is present in the upper parts of the esophagus? Squamous cell, perfect answer. What is the most common type of cancer that is involving the distal parts of the esophagus? Adeno. Okay, what is the risk factor for esophageal adenocarcinoma? Barrett's esophagus, not exactly GERD. Okay, GERD and then Barrett's esophagus. Okay, all right. Technically Barrett's esophagus and then GERD. Okay, your answer more or less is also the correct. Now, is there any confusion between all these things, all these terms, all these conditions? Yes, no? Right? Okay, now we try to understand in what people actually happens this GERD and Barrett's esophagus. Okay, what is the most common risk factor for development of Barrett's esophagus? Yes, it is, perfectly smoking and related down to alcoholism. Okay, that is the risk factor, alcoholism. Okay, I'm getting into these details because I think this is the first time that you are learning about these diseases. All right, so that's the reason I wanted you to learn perfectly here so that you can actually understand. You need not read them twice or thrice in the radiographic images later on that comes down in surgery department. So that's the reason I'm taking time to explain this clearly here itself. All right, now the condition you also have to understand here, one thing is that it might happen in males in this more males, and it happens in the sixth decades. So here is the logical point. One thing, if it is happening in the obese males and sixth decades, okay, these are the comorbidities that are around here. So which means to say, if the patient is coming down in his sixth decade, the life expectancy of a human being right now is something around like 68 to 72 years in different countries. It means to say the patient has already come down to you when it is advanced. That is the catch point here. It is already advanced, which means to say whenever a patient is complaining of GERD, whenever a patient is complaining of this difficulty, you please do not ignore it, because this might be happening because of Barrett's esophagus, or it might be happening because of GERD, which will eventually already could have developed an esophageal carcinoma. And esophageal carcinoma is malignant, and yes, the quality of life is much worse, and the patient will eventually die. Okay, so do not ignore a complaint of GERD. That is what I wanted to say here. So right now, how do you actually diagnose it? The diagnosis is actually, you see here, there are two types of diagnostic things here. One, you have to understand, you could have already understood, it is conversion of the squamous cell to the columnar epithelium. It is nothing non-columnar epithelium, it is no other, it is just nothing but your intestinal columnar epithelium, okay? Intestinal columnar metaplasia, to be exact. Now let us try to use this theory into radiology and see what exactly is this one. So is this concept clear now? Yes, guys, right? It is the intestinal columnar metaplasia that is actually happening here, okay? And hallmark feature, there is something hallmark feature, I'll give you this extra information here. It is the goblet cells, okay? Goblet cells that are being produced inside the intestinal columnar epithelium, which is the hallmark feature. But that is on pathology though. But let us try to get down. The investigation of choice for relating down to this one is barium swallow. Okay, it is barium swallow, and let's try to understand the whole 3 points as a single thing. Let's try to understand the esophageal carcinomas and the GERD and all other things together. Okay, esophageal carcinoma has a very poor prognosis. That is what I'm saying. 50% of the patients will have metastasis upon initial presentation. So the lack of esophageal cirrhosis and lead supply of the lymphatics aid in the extension and dissemination of the esophagus. So more lymphatic spread is happening here, and a combination of long-term alcohol and tobacco are associated with the higher risk of esophageal carcinoma, and which are obviously the reasons for Barrett's esophagus and obviously the reasons for GERD as well. All right. Now, esophageal malignancies are either squamous cell carcinomas or adenocarcinomas, which adenocarcinoma is increasing in prevalence. The increasing in prevalence, why is it happens? It is happening because of the Barrett's esophagus, which in process actually also has the gastric esophageal reflux disease that plays a major role into it. Perfect. It is quite simple. I already explained all these things to you. And what do we do for the investigation purpose? We do investigation as a barium esophagogram, which is the initial study, and the patient will complain of dysphagia, which should actually suggest this diagnosis, right? So dysphagia to mostly liquids and then eventually to solids. See, try to understand one thing. If the gastric mucosa is being, if the esophageal mucosa has been irritated by a lot by the gastric acid, carcinoma it will eventually develop when there is an erosion, right? So which means to say slowly first the erosion happens. Erosion, then healing, erosion, healing, fibrosis will happen, and then finally it becomes a stricture. So which means to say, now you tell me, what is the common risk factor for esophageal strictures as well? Isn't it GERD? Isn't it Barrett's esophagus as well? Right? So a stricture converting down itself down into the neoplastic tissue over the excessive stimulation by alcohol and tobacco is called as esophageal carcinoma. So esophageal carcinoma is not a different entity by itself. It is a condition that is related down to it. So remember, GERD is a symptom. Barrett's esophagus is a symptom to esophageal carcinoma, but they are not separate diseases. Did you understand this? Don't confuse yourself with these things, okay? Barrett's esophagus and GERD are clinical conditions which are the presenting factors, which are the presenting symptoms of an esophageal carcinoma patient. Understand this? Right? So esophageal carcinoma can happen in one or more forms, okay, which can happen because of annular constricting lesions, or it can present down as the polypoid mass, okay, polypoid mass, and a superficial infiltrating lesions or ulceration, which means to say ulceration is possible here, irregularity of the wall, which means to say stricture is possible here, superficial lining, which means to say columnar epithelium metaplasia is happening here, infiltrating lesion, which means to say carcinoma is happening here. So you can see the radiographic appearance of esophageal carcinoma in all these ways. Okay. Then most often they present as a mixture of several of these patterns. So what are the radiographic features of esophageal carcinoma? It can be superficial, it can be infiltrating lesion, or it can be ulceration, or it can be irregularity of the wall. So different patterns are possible in esophageal carcinoma. Let's try to understand one thing here. Look at this peculiar image here. Do not confuse this one with the other clinical condition. There is other condition also that shows up an appearance like this, but try to understand it in relation to the pathophysiology that is happening here. The thing is this, you see here, there is an annular constricting lesion of the mid-esophagus. The tumor encircles the normal lumen and it obstructs in this case. You see here, there is a sudden stoppage, okay? There is a sudden stoppage of the mid-esophagus, okay? Which is actually forming an annular constriction-like appearance, okay? Yes, can you appreciate this one? See here, this one, a filling defect is there, and also you see here, there is a sudden stoppage of the esophagus, all right? Oh, I'm sorry. I think, okay. Right? Oh, is it okay now? Is it okay now? Yes? Right, okay. See, that's what I have been talking about before. We just talked about the lymphatic supply and the columnar epithelium as a risk factor and Barrett's esophagus as a risk factor, GERD as a risk factor to esophageal carcinoma. Then we came to know that it is superficial, infiltrating lesion, or ulceration, or irregularity of the wall. Several patterns might be present. Now, you see here in this image, there is a filling defect, okay? And as well as you can also see that there is an annular constriction, a sudden stoppage, a spontaneous stoppage of the flow of the barium. But you see here one thing, there is no expansion of the esophagus. Esophagus still has got its own diameter. There is no expansion of the esophagus here. You see here, the tumor is actually encircling the normal lumen, but is obstructing in this case. So this is actually an obstruction. So that's the reason in the distal part, I don't see any barium flow. But eventually I'm looking at slow barium flow, which means to say it is a partial obstruction. But I tell you only this thing because there is another clinical condition that is called as achalasia cardia, which looks entirely different from this one. Okay, so that's the reason. You see here, there is a vague filling of the barium flow inside the distal part, which means to say it is suggesting a partial to complete obstruction Okay, and you see here there is a filling up of the barium, but there is no increase in the luminal diameter of the esophagus. So this is the characteristic feature of esophageal carcinoma. And you can also see here there is a filling defect that is present down in the right lateral wall of the esophagus. Okay, and the barium is being displaced around it, which means to say I am looking at a mass inside the esophagus, which is obviously an esophageal carcinoma. Very, very simple. It's a polypoid mass. Polypoid in the sense, okay, there is a polyp in the sense an extra growth inside the esophagus. Okay, a polypoid mass inside the esophagus, which is happening down in the, which is eventually called as the carcinoma. But can you take a guess and tell me if this is a squamous cell carcinoma or an adenocell carcinoma? You see, it is happening in the thoracic segment. Okay, middle part to lower part. No, middle part to lower part. Middle part to lower part, it must be happening because of adenocarcinoma. All right. In the most of the upper parts, okay, above the thoracic and the cervical regions, okay, upper parts, mid esophagus. Now let us take it as not three different parts, but let us take it as the upper part of the esophagus and the lower part of the esophagus. Lower part, generally, I'm talking about half of the thoracic segment and full abdominal segment. So that must be happening because of an adenocarcinoma. You understand here? Okay, so this must be most probably an adenocarcinoma. All right, and you can see here there is an irregular and rigid, okay, and a small ulceration. You see here ulceration is a filling one. That is what we talked. Excessive filling of the excessive filling of the barium, right? And you see here there is a filling defect, irregular and rigid wall of the esophagus. See, the walls of the esophagus should be smooth, but I don't see any smoothness here, but I see a rigidity here. Okay, you see here rigidity around this place, and there you see here partial filling of the esophagus, barium flow in the distal parts. So that is actually again suggesting me that I'm looking at an esophageal carcinoma. But let us not try to make a differentiation of squamous cell carcinoma or adenocarcinoma here itself. There is some kind of a technical way, but most probably you have to understand that this is a diagnosis of esophageal carcinoma. Okay, this can be asked as a picture-based question. Okay, the following picture indicates if it is a esophageal carcinoma or adenocarcinoma of the esophagus. Forget about the squamous cell because that technical detail is not necessary for you at this level. All right, it will confuse you more, right? I will not talk about the hiatal hernia. We will start talking about the this hiatal hernia in tomorrow. Gastric esophageal reflux, I think we will complete it in very simple. Remember, I have already taught about this one before. Gastric esophagus reflux disease may be evident during fluoroscopy when barium is seen to move into the stomach and into retrograde fashion down into the esophagus. Gastric esophageal reflux is nothing but the re-entry of the gastric acid into the esophagus. So since you are doing the fluoroscopic examination on video itself, in real time itself, you can see the little amount of barium entering back into the esophagus. Simple diagnosis, okay, that way itself. I cannot explain better than this. Diagrammatically or the picture wise, it is difficult to understand this one. You can actually see the barium flowing back again into the esophagus. Okay, I don't think it is difficult to imagine this condition. And but reflux is intermittent. Okay, it is occasional, so you have to it may occur or may not occur during the examination. In the absence of reflux does not exclude reflux. Okay, the absence of reflux does not exclude the reflux, and demonstration of a reflux does not necessarily the indicate that the patient has the complications of GERD. Okay, so which one is esophagitis? Strictures and the Barrett's esophagus are the complications of GERD. So a presence of a reflux does not necessarily indicate that the patient is suffering from esophagitis, stricture, or Barrett's esophagus. Or the absence of a reflux does not technically indicate that the patient is not suffering from all these conditions. Okay, this statement might be a little confusing, but understand one thing here: the complications of GERD will be coming only if the patient is in severe condition. Okay, so what is the risk factor of esophagitis? Risk factor of esophagitis, it is GERD. All right, is GERD, and the patient will eventually, the patient here complains not only because of dysphagia, the patient usually complains, you see here, it is the inflammation of the esophagus, so the patient complains here odynophagia. So there is a difficulty in swallowing as well as pain after swallowing, pain during swallowing. So esophagitis is a classical condition. Well, I can talk more about esophagitis, but I fairly doesn't think that you guys have to learn about it here in this step itself, because there are 3 to 4 types of esophagitis. Okay, drug-induced esophagitis, corrosive esophagitis, eosino- eosinophilic esophagitis. Okay, and then Barrett's esophagus. All we have a lot of conditions, malarious, Boyer heavy. All of them are the diagnosis that is made up on barium swallow itself. But if you wanted to learn about them, yes, I will talk them in a very brief manner. But if you do not want to learn about them, okay, let us leave it off here and end the class today. Okay. There are something around like 6 to 8 conditions that are associated with it. At least you should be knowing about the names of them. Did you hear those names? Okay, let me tell you the names so that you can actually try to find out the simple definitions of them. Did you know Mallory via stare? Did you learn about Boyer heavy? Okay, Boyer heavy syndrome. Okay, try to find all these terms then. Okay, Boyer heavy syndrome. Then you know about nutcrackers, nutcracker esophagus. Okay, maybe tomorrow, in the next class, before you come down to the next session, try to find out all these conditions. Okay, all of them are associated with each other, but we will not be learning about their radiographic features. All right, all of them, barium study is the one that is actually being done. Okay, then try to learn a little bit about the pathophysiology of esophagitis. Okay, where there are 3 types: drug-induced, eosinophilic, okay, eosinophilic, and then Barrett's esophagus. All of them eventually will lead down to, okay, all of them are related down to GERD, all of them are related down to esophageal carcinoma and stricture formation. Okay, so these are all the risk factors. So that's the reason I wish you can learn about esophagitis in much more detail. All right, so I have to tell you one thing: we have done till only the parts of the esophagus. It gets more and more deeper. Okay, it gets more and more difficult for the next coming uh, parts, something like gastric ulcers, gastric carcinomas, and you see here we still have a lot of conditions here. Okay, a lot of anatomy to learn, a lot of pathophysiologic associations to be learned here. Okay, and then once you understand them, radiographic features becomes so easy. So I think I will take much more time for this chapter as well, this one, and then the obstructions I will take much more time. And after that, I think we are done almost with the 70% of your radiology syllabus. There are only 2 other chapters that are left. Okay, we will be dealing about musculoskeletal system in 2 chapters, and we will be dealing with CNS in one chapter, and then we are done. 70% of your radiology classes is already complete now, right? So any doubts for today's session? Right? Okay. Please read them back, revise them back. Okay. Also make sure that you guys read these chapters. Okay, this chapter and the next 16th chapter that has been left out. Okay, read them beforehand so that you can actually understand it next time when I'm teaching. Okay, because if you read it for the first time, it is difficult. Or even if he explained it and then you are reading back again, it will become more difficult. So that's the reason I want you to do more and more revisions in the GI part itself, GI, respiratory, and central nervous system. Essay questions, case studies will be coming down from this one. So please don't miss out these chapters. All right. Right. I think so. Then we call it a day today. It's already a long time for our class. Right. I think if you don't have any doubts, we will end the story here. All right. Okay. So have a nice time, guys. Thanks for your patience. Bye-bye. Right. And we will learn about this hiatal hernias when we are starting to learn about the stomach, okay? Because it is related to the stomach. So I'll teach